This is a 65-year-old patient with significant comorbidities, including COPD, osteoporosis, and other medical conditions. Patient status post-fall, and certainly she had lower back pain for a long time. As you see, there's significant abnormalities in the lower lumbar spine, but the location of the new pain is very well corresponding to L1 compression fracture, which could be considered 60 to 70%. Surprisingly, patient has no radiculopathy whatsoever and no sign of myelopathy whatsoever. So the patient's pain is in axial and correspond to this level. And in the MRI that was taken pretty soon after, as well, you see there is a stenosis there, but it's not severe by any means. And obviously the broken bone is lights up in STIR sequence, and with a fresh fracture that explains the pain very completely. Mostly the fear is here worsening of the situation. Obviously there is not enough bone there to perform a kyphoplasty. And this patient was taken to the surgery, and in a regular case with a patient with a good condition, younger patient, certainly corpectomy is still I consider the standard of care, but that requires lateral approach, opening in this level quite significantly high up, maybe resecting some of the ribs to get a better approach there. And we should not ever underestimate invasiveness of a corpectomy. We are talking about significant blood loss, ICU stay, and in this patient, definitely with the condition that patient have, including significant medical condition, COPD, this would not be an option at all. Alternatively, I have been doing in the last 10 years a few dozen of what I called double MIS OLIF cage instead of a corpectomy. What practically is to support the broken part here. In the corpectomy, you remove entire bone here and you put expandable cage that goes from one end place to another. And corpectomy is the part that causing significant blood loss. In this procedure, though, we remove or refresh the surface of the bone as much as possible, and then we put two large cages above and below the fracture. Practically, we use patient's bone as a fusion material, and all of this procedure is done minimally invasively. Here you see first I put a Gemcitabine in, get some bone marrow, and I enter one of the discs underneath the broken segment. Here's the neuromonitoring probe. Here you see it in the AP. And once we enter the disc, we perform the discectomy, dilate, and literally refresh the surface of the bone, what's remaining of it, to put a quite large cage in. And again, here the bone is completely broken. We just want to refresh the material so bone has a path to grow. Here we do the so-called in situ rotation. The cage goes in the lower profile and it then turns to the proper direction. And here again you see the same. Here you see as well how I put significant amount of biologic, as you see here, in that space before the cage is placed. In the same fashion, I put Gemcitabine, the bone marrow from each level. We get 5 cc of bone marrow in each level. Now, here, with the broken bone osteoporosis, I decide to go 2 levels above, 2 levels below, which is more or less standard. Some people even say you should go 3 levels above and below. And since most of the weight is carried in the anterior part, I very consciously decide to put a cage in each level, so patient weight is carried mostly in the anterior part of the vertebral body. Certainly, if I was going to do corpectomy, that is long enough of a surgery that I wouldn't really bother to put cages in other levels. and just rely on posterior instrumentation. But here, each of the cage placement is less than 5 minutes. Here again, you see the in situ rotation. Here, discectomy, the cage is placed and rotated. Then in the same fashion, now we move it segmentally, adjust X-rays to the level of interest before we then start again putting Jamshid, getting bone marrow from each level. It only takes the first 5 cc of the bone marrow. After that, what you receive from the vertebral body is mostly just blood. And then we go above the level of the fracture and do the same. We do enter the disc, do the discectomy, prepare the end plate, refresh the surface of the bone, and then put a cage in and practically bridge the broken piece after the surface of the bone is prepped with 2 cages, the double caging OLIF instead of a corpectomy. And here you see that the same in the AP view. Now then we enter the disc above again for the same reason. This is what a special procedure, we call it OTIF, oblique thoracic lumbar interbody fusion. This is 11-12. It is going transcambine and entering the disc with the neuromonitoring, they're preparing the end plate and putting again a cage in. Again, the anterior part is performed so that it follows the natural habit of the spine that most of the weight goes anteriorly. So we are not relying only on posterior elements, especially with a patient who has quite significant osteoporosis. As you see here, now we finish putting K-wires, and then after the K-wires are placed, there's a process that we literally decorticate the surface of the bone, as you see here, and then put all the screws in place. Now, here you see that we have skipped the broken segments. Often I try to put the short screw in the broken segment. Here it wasn't really any space, reasonable space that I could put a screw in. And here you see that the rod is going in. If you see carefully, you see that the rod is first entered in the wrong bend, so we can pass the thoracolumbar kyphosis segment and then turn down, and then we put it in place and lock it in place. These are the final AP and lateral. And now I'm going to show you the post-operative CT. In a complex case like that, I have been taking always post-operative CT, which in my opinion has really improved my learning curve. Now here is the sagittal and axial bone windows. And here you see it top to bottom. When I come to the midline position here, you see the double caging instead of corpectomy. Certainly there's a segment still there. And so far, only in probably 2.5 dozen patients, I had to go later on and do additional laminectomy. Obviously, I will observe this patient very closely. If there's any sign of stenosis, a minimal laminectomy can be performed. But let's look at the screws in. With the double C-arm, the accuracy of screw placement is tremendous. And you see here that the patient has a natural rotation of the body, but in the X-ray in the OR, we can adjust the X-rays exactly for a true lateral and AP. And these are the 11 cage, the 12 screws. As you see, they're centered exactly on the pedicle. L1 is skipped, then L2 is, as you see here. Pedicle are not very big, but we still are. Sometimes I prefer lateral breach rather than putting a small screw that's prone to breakage. And here is the L2 and L3. And again, you see the pedicles are not very big, but with double C-arm technique, we can be exactly centered on the screws on the pedicle, the screws on the pedicle. And I'm going to go back and forth here in the sagittal. Then I'm going to show you the 3D view of the construct and coronal view as well. Which you see that quite significant stabilization anteriorly, and here you see the 3D view of that. Now, page surgery was done yesterday. Now, the performance of this surgery was about 85 minutes. Our blood loss in this surgery was about 80 cc. And patient has already stood up yesterday. Today she's going to be ambulating, and I'm hoping to discharge her today. She has no leg pain, no claudication, but she has obviously axial back pain, which is controlled. This patient will be observed very closely. Again, in one case, in more than 2.5 dozen of cases, I had to go in and do additional laminectomy. My hope is that by stabilization, the progress of disease stops and there is no additional need for any other surgery. I will keep you updated regarding the progress of this case.